Hello everyone, how are you all? All right, I'm also good. I hope you guys got some break in between this 1 week and you were also able to finish or catch up with few of the things that you were left behind, right? So we are starting obstetrics class 1 today, and hopefully we will need another class for obstetrics and we should be able to finish the obs as well. So let's start our tonight's session. For obstetrics, we normally follow John Murtagh and also Kaplan Strip2CK. As you can see in here, you might have noticed that JM 6th edition, why we have written that. So JM 7th and 8th edition, they only have 2 chapters for obstetrics. So the 2 chapter is the basic antenatal care and postnatal care. But these 2 chapters are only in JM 6th edition, but these are quite important chapters and we still follow this. Okay, I don't know why they haven't included these 2 chapters in 7th and 8th edition, but these are quite important and even more important than these 2 chapters. So you'll definitely go through basic antenatal care and postnatal care from the JM 8th edition. But for these 2 chapters, we will go through JM 6th edition. Now, you might not have 6th edition because we haven't shared it. So we can upload that 6th edition to your Facebook, so you can go through that as well. Handbook of multiple choice questions. So the handbook also have like a good amount of questions from gynae and obstetrics with explanation, as you can know. So I would also advise you to go through the handbook, get an understanding about the topics which is important for obstetrics. We normally don't ask you to follow any specific book for obstetrics, but if you want to know that if there is any book that you can read, there is Lillian Jones. I really don't want you to go through this because most of the important things will be discussed in the class, and some of the important things we will also take from Lillian Jones anyway. So you don't need to read it separately. Kaplan Strip2CK is really a good book for obstetrics, so you can go through that and then definitely solve some questions from QBank and past questions. Okay, so that will be your preparation for obstetrics. Starting with high-risk pregnancy. For high-risk pregnancy, our notes have everything. So the note is all that you would need. So I have included things from Kaplan Strip2CK, Lillian Jones, and also from John Murtagh. Okay, so you'll just need to go through that. Then for infection in pregnancy, we will go through that from John Murtagh. Starting with high-risk pregnancy. So there are lots of pregnancy which is high risk, and one of the most important one is advanced maternal age. And who are advanced maternal age? So any women more than 35 years, they are, and if they are pregnant, they are called advanced maternal age. And why it is high risk? Because as the age goes higher than 35, there is an increased risk of chromosomal abnormalities or genetic defects in the baby. And the most common chromosomal abnormality is Down syndrome, which is trisomy 21. Now, sometimes question asks that what is the risk of having a Down syndrome baby in a 40-year-old pregnant patient or 40-year-old mother? So the risk of having Down syndrome baby is 1 in 110. What is the risk in 45-year-old? 1 in 32. 49, 1 in 12. So I would at least these 4, 35, 40, 45, These three is more important. So try to remember this risk of Down syndrome in advanced maternal age patient. As we're talking about chromosomal abnormalities, as you know that human being has got two sets of 23 pair of chromosomes, and so you will get mainly 23 into 23, so from father and mother, which is 46. Sometimes if there is a extra chromosome, that is what we call as trisomy. The most common trisomy in first trimester pregnancy loss is trisomy 16. And the most common trisomy at term is trisomy 21, which is Down syndrome. So question can come like that, like what is the most common chromosomal abnormalities in a term baby? So common chromosomal abnormality in a term baby is trisomy 21, whereas if question asks that what is the most common cause of first trimester pregnancy loss as part of chromosomal abnormality, that is trisomy 16. Okay, so try to remember these two. Now, these are the list of all high-risk obstetrics patient. So the first one is elderly primigravida, which means never been pregnant before. For the first time, patient is pregnant and her age is more than 35. Then grand multigravida, so someone who has got 5 or more pregnancy. Previous history of complicated labor or delivery, previous cesarean section, hypertension, obesity, diabetes. So all of these are high-risk patient. The important ones that comes in exam is hypertensive disorders in pregnancy, which includes preeclampsia, eclampsia, and gestational hypertension. So hypertensive disorders in pregnancy. Are you guys with me so far? You guys are okay? Brilliant. So hypertensive disorders in pregnancy, we divide the hypertensive disorders in pregnancy into multiple types. So there is gestational hypertension, where patient gets hypertension after 20 weeks of pregnancy for the first time in her life. Remember, it has to be first time in her life she has been diagnosed as hypertensive after 20th week of pregnancy. Okay, so if it is only hypertension, but there is no proteinuria, that means she's not losing any protein in her urine, that will be termed as gestational hypertension or pregnancy-induced hypertension. Whereas, let's say patient has got hypertension, all of these is after 20 weeks, not before. Patient has got hypertension and also losing protein in the urine, that becomes preeclampsia. When a preeclampsia patient develops convulsion or seizure, that's the time we call it eclampsia. So we have got gestational hypertension, preeclampsia, eclampsia. So that's what they have talked in here. So pregnancy-induced hypertension when systolic blood pressure more than 140, diastolic more than 90, occurring for the first time after 20 weeks of pregnancy. Then we have got preeclampsia. Preeclampsia, the John Murtagh has divided it as mild and severe preeclampsia. Mild is when the blood pressure is up to 170 by 110, and severe is when it is more than 170 by 110. Okay? So now you know what is pregnancy-induced hypertension, what is mild preeclampsia, what is severe preeclampsia. So what about if someone was already diagnosed as hypertensive before 20 weeks of pregnancy? That becomes chronic hypertension or essential hypertension. So if a patient was already hypertensive even before getting pregnant, that means it was like maybe essential hypertension. Now, if you, let's say you have got a patient who is more than 20th week of pregnant, and you found patient is having hypertension, you want to know that if the patient is losing protein in her urine because you want to rule out preeclampsia, what test you would do? You'll need to do some urine test to confirm the proteinuria, right? So the first test you would do is urine dipstick, and the dipstick can say that yes, patient is losing some protein, so +1, 2 plus, 3 plus, but it is not confirmatory. To confirm the proteinuria, the test that you would do is called urinary albumin-creatinine ratio. So albumin-creatinine ratio is the most appropriate test for proteinuria. If that is not in the option, then you can do the 24-hour urinary protein. Any of these two will be fine to check for proteinuria. Okay, so albumin-creatinine ratio or 24-hour urinary protein. Now, gestational hypertension, we talked about that. Gestational hypertension is hypertension that has occurred after 20 weeks of pregnancy, but doesn't have any other abnormal symptoms of preeclampsia, or it doesn't have any proteinuria as well. Now, remember, preeclampsia doesn't necessarily only needs proteinuria. It can have multiple other things also because it is a multi-system disorder. So the first thing is definitely patient needs to be hypertensive. And then, yes, proteinuria is a very important finding for preeclampsia diagnosis. But how much proteinuria? So proteinuria more than 300 per 24 hour, or albumin creatinine ratio more than 30. Do you need to remember any of them? No. Only know that patient needs proteinuria. Patient with preeclampsia can also have renal failure or renal insufficiency. They can also involve the liver. So patient with preeclampsia, they can get a right upper quadrant pain, which is because sometimes liver can get inflamed also. So right upper quadrant pain with elevated ALT, which is alanine aminotransferase. So raised serum transaminase, ALT, AST can be found as well. Neurological, so patient can have convulsion, but very important, hyperreflexia, clonus, they can have headache, they can have blurring of vision, they can have hyperreflexia, as we already know. They can also have thrombocytopenia and hemolysis. So you can see that it's a multi-system disorder, not just hypertension and proteinuria. These patients can have renal failure, they can have liver impairment, they can have neurological problems, they can have hematological problems. Now, talking about all of this, if a patient with preeclampsia has got right upper quadrant abdominal pain, has got severe headache, blurring of vision, thrombocytopenia, hemolysis, or liver enzyme abnormality. So any of this is there, even renal failure. If any of this is there in a preeclampsia patient, it means it has involved the organ, and it is already a severe preeclampsia at that time. So to confirm severe preeclampsia, either patient needs blood pressure more than 170 by 110 and or any of this that we discussed. Okay? So far clear, everyone? Remember one thing, that preeclampsia, the blood pressure will return to normal within 3 months of delivery. So it will not be like patient will continue to have hypertension even after delivery. And Dr. Urmi, that is right. Edema, proteinuria, hypertension, all preeclampsia. Yes, so HELLP syndrome, very good. So HELLP syndrome is a feature of impending eclampsia. So HELLP syndrome is hemolysis, EL for elevated liver enzymes, and LP for low platelet, which is thrombocytopenia. So hemolysis, elevated liver enzyme, low platelet, that is HELLP syndrome. And there is also a feature of severe preeclampsia. Okay. So we have got chronic hypertension, which is like hypertension before pregnancy. So these are the risk factor of preeclampsia. Doesn't come in exam. You can give it a read if you want. And what are the risk of eclampsia, preeclampsia? That is important to know that why we are very worried about it. Because as you can see, it can affect a lot of organs for the mother. And if mother is affected, then the baby will also get affected, right? So now that you can at least diagnose, is it a gestational hypertension? Is it preeclampsia? If it is preeclampsia, is it mild or severe? Or it is a eclampsia? Once you make that diagnosis, your management will depend on the severity and also multiple other factors. So always remember, the first thing is it is mainly based on hypertension. So we want to keep the blood pressure below 160 by 100. So that is the optimal blood pressure in this patient. So always try to keep it below 160 by 100. Now, you can't use all antihypertensive in a pregnant patient. So you can't usually, so we normally don't give ACE inhibitor or ARB. We try not to give diuretics. The common antihypertensive in pregnancy for mild preeclampsia or for mild hypertension, we use methyl dopa, which is an oral antihypertensive. And we can also use oral beta blocker. So we have got oral labetalol, atenolol. So these are also commonly used oral antihypertensive. So the common is methyl dopa, beta blocker, and nifedipine. And all of this, labetalol, hydralazine, this also comes as IV antihypertensive. So when we want the blood pressure to drop a little bit faster for a rapid control of blood pressure, we can use hydralazine or IV labetalol. Okay? So antihypertensive drugs, methyl dopa is for mild hypertension. For severe hypertension, the choice will be beta blocker. If it is really, really high, like above 200, then yes, you would rather choose something like an IV to drop it down. Now, let's talk about further treatment. So let's say you have got a patient as severe preeclampsia. So severe preeclampsia, you know that either the blood pressure is above 170 by 100, or patient has got any of those severe feature, renal failure, liver failure, the hematological problem, neurological problem, that is a severe preeclampsia. For severe preeclampsia, patient needs to be admitted in the hospital. Then we need to give IV antihypertensive, which is IV hydralazine most of the time. We also give magnesium sulfate because severe preeclampsia patient is high risk to develop eclampsia eventually. So to prevent convulsion, you give magnesium sulfate. Okay? And if there is a possibility that the labor is going to happen before 34 weeks of gestation, then you also give a steroid IM to bring the fetal lung maturity. If you remember, less than 34 weeks baby, they are premature and they don't have surfactant and they have a high risk to develop respiratory distress. So to avoid that, if there is a possibility that labor might be induced or labor might happen before 34 weeks, you will give the mother a corticosteroid therapy. Okay. The best treatment for severe preeclampsia is early delivery, either by C-section or induction. Does it make sense, guys? Like, what will be the treatment of severe preeclampsia? So severe preeclampsia, control blood pressure, give magnesium sulfate, and consider a steroid if there is a possibility of the mother getting into delivery less than 34 weeks. But the treatment or the best way is early delivery by C-section or vaginal delivery if it is possible, which means induction of labor. Now, so we know about treatment of severe preeclampsia. How about a patient already developed convulsion, which means patient is already having eclampsia? A patient who has convulsion, first thing is to manage the convulsion, which means make sure patient airway is patent, patient is breathing properly, oxygen is there. So if oxygen is low, start the patient with oxygen. So the initial treatment is just airway, breathing, circulation, ABC. And then you also need to give magnesium sulfate in that patient to prevent further episodes of convulsion. If magnesium sulfate is not in the option, then alternative will be diazepam or clonazepam. And a patient who has convulsion or eclampsia needs to have termination of delivery immediately, which is most of the time C-section. We talked about HELLP syndrome. It is already severe preeclampsia if a patient has got HELLP syndrome. Now, in this chart, there is a summary of management of pregnancy-induced hypertension and preeclampsia. So let's say your patient has only gestational hypertension, no preeclampsia. What would you do? So for patient with gestational hypertension, most of the time you might not even need to do anything. You just keep the blood pressure, or you can just monitor the blood pressure. And if it is really high, then yes, you can start antihypertensive for that patient. And really high means above 160 by 100. We already know what would you do in a severe preeclampsia patient. The severe preeclampsia and moderate preeclampsia, although we don't usually differ in that way, both of them will be treated in the same way. Only mild preeclampsia patient, you can just keep an eye and treat if needed. We'll come into that, don't worry. So before we go into week by week management of preeclampsia, how we can prevent preeclampsia? The way to prevent preeclampsia is prophylactic aspirin given to women at high risk of developing preeclampsia results in a modest reduction. So aspirin is a good preventative medication, and also calcium. So it can reduce 50% chance of gestational hypertension and preeclampsia, whereas vitamin C and E hasn't been shown to be effective. So it comes in exam. I have seen a couple of questions like that. So aspirin and calcium, both of them, they can reduce the possibility of gestational hypertension and preeclampsia. If both of them are in the option, which one will you choose? Calcium. Now, preeclampsia diagnosed before 32 weeks of pregnancy. So sometimes according to the week of pregnancy, the management might be different. Okay. So before the 32nd week of pregnancy, the objective is if we can at least continue the pregnancy until 35th week. Because by the time it is 35 week, we know that baby will be mature. Okay. So if your patient is less than 32 week of pregnant, your best idea is if we can at least prolong the pregnancy up to 35. So how would we do that? So we just keep monitoring the baby and the mother. So baby, we check the daily fetal movement. We do the cardiotocogram, which is CTG, and we see that if it is getting any worse. Okay, so most of the time it will be just keeping an eye on the patient, and definitely depending on like how bad is the blood pressure, you can also start the patient with some blood pressure medication, and that's it. Usually you would not go for delivery for this patient until mother or the baby is unstable. Same management is up to 35th week. So up to 35th week, preeclampsia management is same. So that means if mother and baby is stable, you would like to continue the pregnancy until 35. What about preeclampsia diagnosed after 35 week? For these patients, you can actually go for delivery. So preeclampsia diagnosed after 35 week should be controlled rapidly, labor induced or C-section performed depending on the condition of the baby and the cervix. Women with preeclampsia should not be allowed to exceed full term. That's important. Many times we like to continue the pregnancy up to term, which is 37. But for preeclampsia patient, we normally would like to have the delivery done, either C-section or induction, before term. Okay? Care after birth. So once a preeclampsia patient is once the preeclampsia mother had the delivery done, you need to closely monitor her blood pressure until it resolves. Most of the time, as you know, within 3 months, the blood pressure should come down. Now, we were discussing about medical management with magnesium sulfate, right? Now, before I go into that, I want to discuss a little bit just to give you a summary of preeclampsia management, because it's a lot, right? So just think in that way. If your patient has got gestational hypertension, the treatment is only first start with checking the blood pressure at home to confirm whether patient has got high blood pressure or not. So do multiple readings. If it is confirmed less than 160 by 100, you can monitor the blood pressure, keep an eye. More than that, you start the patient with antihypertensive. If a patient develops preeclampsia, if it is mild preeclampsia, then just manage with blood pressure medication. If it is severe preeclampsia, then along with blood pressure medication, we also add magnesium sulfate. If it is eclampsia, same. First, definitely if the patient is convulsive, treat the convulsion and add a magnesium sulfate. So magnesium sulfate is very important management for preeclampsia, eclampsia. So why it is important? Because it reduces the risk of recurrent seizure. And it is given intravenously or intramuscular. So initial dose is 4 gram over 10 to 15 minutes. And then continuing treatment is 1 gram per hour. Now, this is one of the doses that comes in exam. So have a look in here. Loading dose is 4 gram and maintenance dose is 1 gram per hour for 24 hours. Now, once you start a patient with magnesium sulfate, it has also some risk. So it can quite easily, it can have a magnesium toxicity. So because magnesium is a smooth muscle relaxant, so sometimes it can cause a lot of side effect. How we normally look at it? When a patient is on magnesium sulfate, we look at the tendon reflex, we check their respiratory rate and urine output to detect magnesium toxicity. If a patient who is on magnesium sulfate start having respiratory arrest or respiratory depression, you stop the magnesium sulfate and give 1 gram calcium gluconate because this is the antidote of magnesium toxicity. Okay, so if there is any respiratory depression or arrest, stop the medication, give calcium gluconate. If there is absence of patellar tendon reflex, stop the magnesium until reflex return. Okay, if there is poor urinary output, if there is no other sign of magnesium toxicity, reduce the rate of IV infusion to 0.5 gram instead of 1 gram per hour. So this all comes in exam. What would you do if there is loss of tendon reflex? What would you do if there is poor urinary output? Very, very important. As part of the medical treatment for eclampsia, we know that you need to control the blood pressure. You will need to give the magnesium sulfate, but as part of delivery, this patient should be delivered irrespective of the gestational age. So it doesn't matter whether the gestational age is 32 or 35, you just go for cesarean section most of the time in this patient. Okay, but sometimes we can even try the induction of labor if it is possible. Someone's microphone was on. Any questions from preeclampsia, eclampsia? Definitive treatment is termination for eclampsia. Okay. Magnesium sulfate is the first line. Methyl dopa beta blocker can be used together. Usually we don't do that, but yes, it can be. But you normally don't do that. Beta blocker usually is given in more severe severe blood pressure patient. Difference between superimposed preeclampsia and preeclampsia. Superimposed, I don't think there is a term of superimposed preeclampsia. It's superimposed hypertension, which means that patient was already hypertensive before getting pregnant, and after getting pregnant, their hypertension has got worse. So if a patient is fitting in front of you, in that case, yes, diazepam will be the first line because that's a anticonvulsion treatment. The thing is, what happens in a patient who has eclampsia or who is actually actively having a seizure, you normally don't give anything. You allow the seizure to stop first. Because when the patient is having the seizure, you can't actually do anything. You can't give medication during that time until the patient is really having a status epilepticus. So most of the time, these are very short convulsion. For a short convulsion, you allow the seizure to stop, and then you give magnesium sulfate. But sometimes there are patients who just keep on having the seizure, then diazepam will be the option. So to go for induction, you need the vaginal area, like it has to be ripe. So you check the vaginal area, the Bishop's score. The Bishop's score will give you an idea if the patient is having a favorable vaginal induct, like if the vagina is favorable to go for induction of labor. We will discuss that later on, but otherwise you'll go for C-section. It's not like that. You can always definitely 5 minutes we can wait without any problem. But if the patient having seizure for more than 15 minutes, that's the time we will be really worried. But 5 minutes, most of the time it will be fine. Moving on. So anemia. So anemia in pregnancy is not uncommon. So what is the most common cause of anemia in pregnancy, guys? Iron deficiency. Yes. So iron deficiency is the most common cause of anemia in pregnancy. So we normally want the hemoglobin to be more than 110. Less than that is anemia. Okay. So there are lots of risk of having iron deficiency or having anemia in pregnancy, but the most common is iron deficiency, about 50% cases. Then other than that, it could be B12 or folic acid deficiency, which is megaloblastic anemia, and then thalassemia. Thalassemia is not very common in Australia, so don't think that just because a patient who is pregnant and has anemia doesn't mean that patient is thalassemic. Okay, very uncommon. So if a pregnant patient is anemic, so you did a test and you found out patient hemoglobin is less than 110, what would you do next? The next thing is to make sure that whether it is iron deficiency anemia or not. So you check the serum ferritin level. If the ferritin level is low, then you can confirm that it is iron deficiency. Let's say ferritin level is normal. So it's not iron deficiency. Then you check the B12 and folic acid. Let's say B12 and folic acid is also normal. Then you do the hemoglobin electrophoresis to rule out thalassemia. So that will be the step-by-step investigation. If you find it is iron deficiency, then treatment will be most of the time oral iron supplement. And if that doesn't work, or if patient having like a very severe iron deficiency, sometimes we go for iron infusion. If it is folic acid deficiency causing the anemia, then you give them folic acid. If it is thalassemia, there is no treatment is possible. So normally just keep an eye. Okay, so that's usually the treatment. Moving on to diabetes during pregnancy. So diabetes mellitus, especially type 1 in pregnancy, requires very meticulous management because during pregnancy, blood sugar can fluctuate a lot. If a patient who has diabetes and it is uncontrolled diabetes, there is always a risk of both the baby and the mother. For baby, the baby can be large for death, which is macrosomia, so can have like increased weight, and lots of fetal abnormalities can happen. For mother, there is increased risk of preeclampsia, polyhydramnios, so lots of effect is there. So managing diabetes during pregnancy is very, very important. So early referral to a diabetic physician like an endocrinologist and an obstetrician is very important. And before you do anything, you need to check their HbA1c, their blood sugar level, kidney function. So basic bloods should be done. The insulin requirement can get increased, even sometimes 2 or 3 times than usual. Okay, so basically this type 1 diabetes patient will be already on insulin. So you refer the patient to a diabetic physician, and then they usually increase the dose of insulin just to keep the diabetes well controlled. So that is usually the treatment. Patient who has a optimum control of diabetes, they usually can have a normal vaginal delivery. But if the baby is very large baby, which is more than 4 kilo weight, evidence of fetal distress, breech presentation, then cesarean section is ideal. Now, type 1 diabetes is not very important for exam, but gestational diabetes is super important for exam. So what is gestational diabetes? Gestational diabetes means that patient has got diabetes during pregnancy. So before pregnancy, patient was never been diabetic. Only patient developed diabetes during pregnancy. Okay? So if a patient has been diagnosed as diabetic during pregnancy, never before pregnancy, that's gestational diabetes mellitus, GDM. How to confirm? So to confirm a patient has got GDM, you have to do a oral glucose tolerance test, OGTT. So previously, people used to do a lot of other things like glucose challenge test and everything. That is no longer required. We only need to do a OGTT. In OGTT, you give the patient a sugar drink, which is 75-gram sugar. And then before you give the sugar, you ask the patient to do fast. So you check the fasting blood sugar, and then 2 hours after giving that glucose drink, you again check the blood sugar. So if fasting is more than 5.5 or 2 hour more than 8.5, you can call the patient as GDM. You should remember this value because sometimes, most of the time, they give you the normal value, but these are the ones which we are supposed to know already. We don't need normal value because this is something which is commonly used during day-to-day practice. So just try to remember what should be the fasting blood glucose more than 5.5, what is 2 hour more than 8.5. Okay. So what is the management for GDM? Now remember, there is a RACGP guideline for gestational diabetes. Please make sure you read it at least once because a lot of questions come from there. So it's important to read at least. What are the risk of GDM? Same like macrosomia, intrauterine fetal death, all of the things that we discussed. Management. Management comes a lot. John Murtagh hasn't given a lot of management, but RACGP has. So the first line is for gestational diabetes, initial couple of weeks, you'll try a dietary management. So you try a lifestyle modification for a couple of weeks, let's say 2 weeks, but it did not work. Then the best management is insulin. Remember, for other diabetic patient, we start them as like oral medication, right? Like metformin, sulfonylureas, those things. But for gestational diabetes, insulin is the best treatment. Now, many times I've seen that nowadays metformin is used in pregnancy. It's not unusual that sometimes they use metformin before trying insulin. But for exam purpose, if question comes in exam that what will be the choice of treatment for gestational diabetes, that should be always insulin. Okay, but remember metformin can be given as well. So These patients also can have delivery at term. Post-delivery, so this is very important. According to John Murtagh, they say that patient should have another OGTT at 6 weeks, then every 5 yearly. Okay, so that's the gem. I'll show you one thing from RSCGP. So according to RSCGP, the follow-up is a bit different. Okay. So RSCGP say that it is important that all women who had GDM have an OGTT to clearly document their glycemic status after pregnancy. So this is usually the 6 weeks. So 6 weeks one is fine. Annual measurement of HbA1c is simple and practical and can be done in a high-risk individual. Another is checking a fasting blood glucose every 1 to 2 years, with the interval depends on the woman's level of risk. So according to RSCGP, they say that you can do a annual HbA1c rather than doing every 5 yearly. 5 years is actually a long time. Okay, so the ideal for this kind of case, you should actually go for, like, I would go for RSCGP rather than John Murtagh in that case, because this was 6th edition. It has changed a lot since then. Okay, so that's your gestational diabetes. Remember, once a patient develops GDM, there is a 30% risk of developing diabetes later on their life. So patient who has GDM, they can get a diabetes later on in their life. That's why we ask you to do this annual HbA1c or fasting blood glucose at least for 5 years. Next, thyroid disorders in pregnancy. Thyroid disorders are not uncommon. Both hypo and hyperthyroidism can be there. So TFT, which is thyroid function test, should be checked at first presentation if past history is relevant, and at 36 weeks. So we'll talk about what are the initial screening tests that we do in a pregnant mother. One of them is thyroid function, especially if there is a past history. And many times there might be a bit of increased requirement of thyroxine or thyroid hormone in a hypothyroid patient, especially when they're pregnant. So normal maintenance dosage is usually increased in pregnancy. Okay. So for hypothyroid patient, you would check their thyroid function test at presentation and at 36 weeks. And most of the time, you will need to increase the dose a little bit. And again, most of the time, these patients already have some specialist. They can always change the dose. Okay. Hyperthyroidism. Hyperthyroidism in pregnancy usually caused by Graves' disease. So for this patient, you need to give them some medication because left untreated, there are lots of fetal and maternal complications for this. So You know that for hyperthyroid patient, especially for Graves' disease patient, the norm, like a non-pregnant patient, has options of surgery, radioiodine therapy, and medication. Radioiodine is contraindicated during pregnancy. And surgery is usually not the best option in pregnancy if we can control the thyroid by medication, right? So what medication we normally give in a non-pregnant patient? The common medication is called carbimazole. But carbimazole has high risk of fetal abnormality if you give it during the first trimester. So as you know that the 9 months of pregnancy has been divided into 3 trimesters. So first trimester is first to third months, 3 to 6 month is third trimester, 6 to 9 month is the third trimester, right? Or up to 12 weeks is first trimester, 12 to 28 weeks is second trimester, after 28 weeks, third trimester. So for patient who is having a hyperthyroidism and you want to give a medication to control it, the first trimester, you can't give carbimazole. So what is the option? The option is propyl thiouracil. So it is usually the preferred agent, but it's not the best medication. But for first trimester, you will change the carbimazole to propyl thiouracil, and then after first trimester, you can restart carbimazole in this patient. Okay, so that's thyroid disorder management in pregnancy. Cardiac disorders in pregnancy. So murmur is common. You can go through that. It's not super important. You can give it a read by yourself. Kidney disease in pregnancy, again, same thing, give it a read. So two other important thing is sometimes question asked that you have got a patient who is pregnant and has got diabetes. So pregnant plus diabetic, and diabetes is uncontrolled. What is the risk of, like, what is the most important risk in this patient, especially for the baby? Macrosomia. Pregnant patient has got a renal failure or kidney impairment. If it is severe kidney impairment, the risk is IUGR, so intrauterine growth restriction. Okay, so sometimes they give both in a patient. So they give a patient who is pregnant, has got well-controlled diabetes, but has got a severe kidney impairment. Well-controlled diabetes, but severe kidney impairment, the risk in the baby is IUGR. Whereas mild kidney failure, but uncontrolled diabetes, the risk is macrosomia. Okay, so the effect depends on which one is worse. If diabetes is worse, then macrosomia. If renal failure is worse, then IUGR. Okay. Lupus or SLE. So pregnancy does not cause any exacerbation of SLE, but SLE can adversely affect pregnancy, which means that pregnancy itself will not cause any problem for SLE, but SLE can cause some effect on pregnancy, right? So what it causes is that it can increase the risk of spontaneous miscarriages. It can increase the risk of preeclampsia, premature baby, IUGR. And even babies sometimes can develop neonatal lupus syndrome, where they develop cardiac abnormalities such as heart block. Okay. So management for SLE in pregnancy is definitely send the patient to her specialist, and the main treatment will be a steroid. And steroid will be the safer option because the other options like sulfasalazine, methotrexate, those are usually not the best management. We also start this patient with low molecular weight heparin or aspirin from 14-week pregnancy until 6 weeks postpartum. Why? Because we want to these SLE patients commonly they can be complicated with deep vein thrombosis or venous thromboembolism. To reduce that effect or to reduce that complication, we put this patient as a prophylactic aspirin or heparin from 14 weeks of pregnancy. Okay, so this is the important one that you need to remember. Any questions so far? The first line investigation for GDM is OGTT. Yes, metformin can cause growth retardation. That's why it is not our best option. But there is lack of evidence on that. All right, guys. So let's take a 10-minute break. And then after that, we will start with the thrombocytopenia during pregnancy. Okay. Thank you. 10-minute break, guys. All right, guys, let's start again. November schedule will be given tomorrow. If there is no previous prediction of thyroid abnormality, should we do it as a routine investigation? But normally, no need. So we'll discuss the basic antenatal care, and then you'll know what are the baseline that we do. Okay, thrombocytopenia in pregnancy. Not very important topic, but just good to know. So the most two common causes of thrombocytopenia, which is low platelet count in pregnancy. One is called gestational thrombocytopenia, and another is immune thrombocytopenia. So many times in pregnancy, the platelet count can get a bit low, especially in the third trimester. It can even go to up like from 75 to 150, right? So sometimes this is normal and nothing really needs to be done. And that is what we call as gestational thrombocytopenia. But if a patient's platelet count goes below 75, then a 2-week course of prednisolone is usually given between 37 to 38 weeks. Because with a platelet count below 75, there is always a high risk of bleeding. Okay, especially if you are going for epidural anesthesia during pregnancy, patient can also end up having a lot of bleeding episodes. So ideally, all you need to know that if a pregnant patient has got a bit of mild thrombocytopenia, otherwise completely normal, then that is gestational thrombocytopenia. Up to 75 platelet count, it is totally fine. We can just keep an eye. But if it is less than 75, then you need to go for some prednisolone. Immune thrombocytopenia is not very important. Give it a read in your own time. Jaundice is specific to pregnancy. So many pregnant patients can have jaundice. Viral hepatitis accounts for 40% cases of jaundice during pregnancy. So that is the common cause. Apart from that, preeclampsia, eclampsia, as you know, it can cause jaundice. But two other specific condition is cholestatic jaundice of pregnancy and acute fatty liver of pregnancy. Acute fatty liver of pregnancy is very rare. So it's not important for your exam, but cholestasis in pregnancy is common. So in these patients who are pregnant, they usually develop a low-grade jaundice and pruritus, which is itching, during the latter half of pregnancy. So usually second or third trimester. And if you check the liver function test, you will find out that their alkaline phosphatase, which is ALP, is very high. So ALP high in a pregnant patient, usually in the second or third trimester, with a bit of jaundice, that is cholestatic jaundice in pregnancy. Okay, so perform liver function test and consider a vitamin K supplementation for this patient. And ideally, you need to refer this patient to an obstetrician for checking the fetus and everything. And most of the time, the jaundice should clear up rapidly after delivery. Okay. Nothing really needs to be done for cholestatic jaundice during pregnancy. Just keep an eye on the baby. That's it. Now, epilepsy during pregnancy, very important topic. A lot of time you will see that patients who are non-epileptic, they're getting pregnant. The problem with this is that pregnancy can increase the episodes of seizure in patients. So about 25% women will have increased number of seizure. Now, the other 25% can have a reduction of seizure also. So we never know what kind of complication an epileptic patient will get during pregnancy. Some may get increased seizure, some may get reduced amount of seizure. But it is important that patient has a well-controlled epilepsy before they try to become pregnant. And by well-controlled, it means at least 2 years, patient did not have any seizure. So that's an ideal thing. So we normally say that if you did not have any seizure for last 2 years, then yes, you can plan for pregnancy. Okay? And this is one of the group of patient who needs to have a high dose folic acid supplementation during pregnancy. Every pregnant patient, they usually take 0.5 milligram folic acid in the first 3 months of pregnancy. But if a patient is known epileptic, then you start them with a high dose, which is 5 milligram folic acid. You start 1 month before they start trying to become pregnant, up to 3 months of the pregnancy. So 1 month before falling pregnant and 3 months after getting pregnant. That's usually the treatment. Now, for epilepsy in pregnancy, all anti-epileptic drugs are potentially teratogenic. That means it can cause birth defect, such as phenytoin can cause cleft lip, cleft palate, congenital heart disease. Sodium valproate, carbamazepine can cause spina bifida. So what kind of medication we can give in a patient who has epilepsy and they're pregnant? That's the main question. So a lot of scenarios comes in exam from this topic. Let's say your patient is a pregnant patient and the patient was on sodium valproate. If a patient is on sodium valproate and they are planning to become pregnant, the next thing you need to look at if the epilepsy is well controlled. Well controlled epilepsy, patient is on sodium valproate and they are just planning to become pregnant. They are not pregnant yet. The best option would be to gradually reduce the valproate and stop the valproate and then give a safer anti-epileptic during pregnancy. Okay, remember they are not pregnant yet. So change sodium valproate to something safer, like carbamazepine is a lot more safer than valproate. So you can change valproate to carbamazepine, but even better at the moment. So nowadays, the newer anti-epileptic, those are commonly used. The newer anti-epileptics are, we have got Keppra or levetiracetam. So levetiracetam or lamotrigine. These are all newer anti-epileptic. This has low risk of fetal abnormalities than those like others like phenytoin, valproate, carbamazepine. So the best option, either if the newer anti-epileptic is not in the option, then change valproate to carbamazepine, or if newer one is in the option, then choose levetiracetam, that's the best, or lamotrigine. Now, what if it is not well controlled? If it is not well controlled, then changing the medication can increase the risk of epilepsy. So we don't change. And we ask the patient not to plan for pregnancy until they become well controlled. Okay? So if it is not well controlled, you advise them not to get pregnant. Now, what if patient is on valproate, but patient is already, like, let's say 6 weeks pregnant or 8 weeks pregnant? When a patient is already pregnant, then we don't actually change the medication because we don't know whether that medication will cause side effect, whether the new medication will actually work. So that's a lot of weather or a lot of uncertainty. So if a patient becomes pregnant on the top of valproate or any other medication, you just continue that medication, but let them know that there will be always a risk of fetal abnormalities and reassure them that it will be checked throughout the pregnancy. Does it make sense, guys? All right. So that is a very important thing to understand because a lot of different kind of questions come in the exam. Remember, most of the anti-epileptic medications also excreted in the breast milk. So sometimes they say that anti-epileptic patient is pregnant, patient has been delivered, or the delivery of the baby is there, but mother is concerned about the breastfeeding. The best anti-epileptic which doesn't get excreted in breastfeeding is valproate. Okay, so sodium valproate is commonly used in breastfeeding mother, but not during pregnancy. So it's an important thing to remember. Okay, so this is mainly all about the epilepsy. Moving on to antepartum hemorrhage. Antepartum hemorrhage is really, really important, like one of the most important after preeclampsia, eclampsia that we have discussed today. So do you guys know what is the common cause of antepartum hemorrhage? Like two commonest cause. Yeah, good. So placental abruption and placenta previa, this is the two most common cause of antepartum hemorrhage. So let's talk about antepartum hemorrhage. So bleeding from the genital tract after 20 weeks of pregnancy and before the onset of labor, that's antepartum hemorrhage. So after 20 weeks of pregnancy and before the onset of labor, if a pregnant patient has a bleeding, that's antepartum hemorrhage. Hemorrhage that occurs before 20 weeks, usually termed as miscarriage. Now, placenta previa. Placenta previa is very important. So all of you should know that what is the usual location of placenta. So placenta is usually, if this is the uterus, placenta should be on the top part or the fundus of the uterus, right? That is the more like the normal location. But sometimes this placenta can come closer to the maternal pelvis or internal os. Like if you see in this picture, you can see that it is coming closer to the os. So there is the term. So when placenta is a low-lying placenta, we call it placenta previa. What is the problem? Problem is when the mother reaches towards pregnancy or towards the end of her pregnancy, which means when they have like the time for delivery, the baby starts descending downwards into the maternal pelvis. But the problem is the placenta is is just obstructing that pathway, right? So when baby descend downwards, the head or the presenting part of the baby start causing pressure on the placenta. And placenta has got like small tiny blood vessels, which are very like they don't have that much of a strength. So with that pressure from the presenting part of the baby, these tiny blood vessels start to get ruptured, causing the bleeding. So this is why the patient will have this bleeding paravaginally. But this is a painless paravaginal bleeding. So painless paravaginal bleeding after 20 weeks of pregnancy before onset of labor, that is placenta previa. Okay? So you need to know all of this. Otherwise, you will not be able to answer this correctly in the exam. Now that you know what is placenta previa, you need to also know that placenta previa has been divided into 4 grades. So you have got grade 1 and 2 and grade 3 and 4. Grade 1 and 2, there you can see that the placenta is just near the os. It's not even like closing the os. These are called minor grade, okay, or minor placenta previa. Whereas grade 3 is almost blocking the internal os, and grade 4 is completely blocking the os. These two are called major placenta previa, which means like these are severe, right? Definitely, because it's almost completely blocking the descent of the baby. It's important because minor and major placenta previa will be treated a bit differently. So let's say a placenta previa patient coming to you for like active vaginal bleeding. What would you do next? Anyone who is actively bleeding, resuscitation comes first. So insert IV line, send the blood for cross-matching, start IV fluid, and then blood transfusion when blood is back. Confirm your diagnosis by doing an ultrasound. So ultrasound will be able to confirm whether it is placenta previa, and if it is placenta previa, what is the grade of placenta previa. If it is a major grade, admit the patient to the hospital for observation. Keep an eye on the patient to see if the bleeding is getting really bad, and check the baby's status, whether the baby is getting any fetal distress or not. And for major grade, usually, if patient continues to bleed, then ideally you will need to go for cesarean section. Okay? But you can, if the mother and baby is stable, then you can keep an eye on them and continue the pregnancy until term. So up to 37 weeks, and then do a cesarean section. So even for major grade, if the bleeding is not very heavy, both mother and baby is stable, you will try to prolong the pregnancy up to term and then go for elective C-section. But if the bleeding is really heavy, mother or baby is unstable, then you just go for C-section in this patient. Okay? So C-section is the safest approach for placenta previa, especially the major grade. So cesarean section is almost always required for major placenta previa, but there are sometimes for grade 1 or grade 2, which means like the minor placenta previa, sometimes there are options of vaginal delivery. So it can be done. So that's pretty much everything you need to know from placenta previa. Any question? Moving on to abruptio placenta or placental abruption. So normally, normally what happens that during delivery, the baby will be delivered first, followed by placental delivery, right? So placenta will separate after delivery of the baby. Now, if during pregnancy, especially like if between 20 weeks of pregnancy up to the onset of labor, during that time, sometimes placenta can be detached from the uterus. And if placenta get detached from the uterus, it can start bleeding. The bleeding can either start accumulating inside the uterus, and the uterus will get more and more bigger because blood is collecting there. That's called concealed variety of abruption. Or patient can have bleeding from parvagina. So blood can come out, which is revealed variety of placental abruption. Let's see if we have got any picture. Yes. So you can see that when placenta has got detached from the uterine wall, if the bleeding is getting collected, then it is concealed variety. And if bleeding is coming out through vagina, that's revealed variety of placental abruption. Because in concealed variety, the blood is collecting, the uterus is getting larger. So you'll see that in this patient, uterus is bigger than the gestational age. Ideally, the symphysiofundal height or the height of the uterus should be plus minus 2 of the gestational age, which means if a patient is 36 weeks pregnant, their uterine size will be 36 plus minus 2 centimeter. So from 34 to 38, that's normal. But in this patient, the 36 weeks can have like maybe even a 40 centimeter symphysiofundal height. So when it is the case, you will be concerned. So for concealed variety, the uterus size will be bigger. Uterus will be very tense because of all the blood collecting, and it will be quite tender. So it is painful, unlike placenta previa, which is painless. Okay? So placental abruption is retroplacental bleeding from actually detachment of the placenta from the uterine wall. So patient with placental abruption will have abdominal pain, parvaginal bleeding, may or may not be. In concealed, there will be no bleeding, only abdominal pain, and a tense, tender uterus, which is large for date. And patient is bleeding heavily, they can also get into hypovolemic shock. So the exact reason why placental abruption occurs, not known, but there are lots of risk factors like smoking, cocaine, multiple pregnancy, all of this can be a cause. So you can give it a read. Management. So again, this patient can be bleeding more than placenta previa patient. So resuscitation is the first thing, and do some blood test if you can. Do a ultrasound and CTG. CTG for fetal assessment to see if the baby is in fetal distress. And many times the bleeding can be very severe in this patient that fetal death can happen. Ultrasound to check that if there is any retroplacental clot, and also to rule out placenta previa. So this is all initial thing, right? So you've done the initial management, resuscitation, doing a cardiotocogram, doing an ultrasound. So do all of those. And after that, the further management will depend on several factors. One, let's say the bleeding is really heavy that fetal death has happened. If baby is dead, the only way to confirm it is by doing an ultrasound. So when you do the ultrasound, you will be able to find out. So if baby is dead, then ideally aim for vaginal delivery. And most of the time, the abruptio placenta patients, the vagina is quite stimulated, and many times, like you will be able to do a induction of labor by rupturing the membrane. So the main thing is that if if the baby is already dead, there is no point of doing a C-section. In that case, you will go for vaginal delivery and possibly a induction of labor by artificial rupture of membrane. If baby is in a like a life-threatening condition or fetal distress is there, then cesarean section will be the ideal thing. Okay, so cesarean section has been recommended where the baby's life is immediately threatened. Make sense, guys? So ideally, if the baby is dead, then aim for vaginal delivery. If there is fetal distress, then you go for C-section. That's the treatment. So I've given a bit of difference from placenta previa abruptio placenta, but you should already understand it. Please give it a read. Patient is already bleeding. So most of the time it is not going to do any more increase of it because the baby is already dead. With the induction of labor, if you can remove the baby, then the idea is as soon as the delivery is happening, then the possible chance of stopping the bleeding is much better. So many times, even if you don't do anything, a spontaneous delivery will happen in this patient because it is hyperstimulated at the time. But no, it's not that case. You can definitely go for vaginal delivery in this patient. It will be more safer than doing a C-section in an unstable patient. We will discuss that induction of labor later on, Dr. Fajia. The bishop square and everything. Moving on to primary PPH. Primary postpartum hemorrhage is loss of more than 500 ml of blood within 24 hours of delivery. So antepartum hemorrhage is done, right? Postpartum hemorrhage, we divide it as primary and secondary. If a patient has bleeding within 24 hours of delivery, that's primary PPH. After 24 hours of delivery, up to 6 weeks postpartum, any bleeding will be secondary PPH. Okay? So what is the most important cause of primary PPH? Uterine atony. Uterine atony is where the uterus becomes soft and lax. Every pregnant patient, like normal patient who delivers a baby, after delivery, their uterus should be contracted and hard, and that makes the bleeding to stop. But uterine atony is when the uterus remains soft and lax even after delivery. So that's the commonest cause. Then we have got retained placenta, we have got genital tract laceration, ruptured uterus, inverted uterus. So all of this. Management. It's a very, very important case in the exam. So if a patient having primary postpartum hemorrhage, the first thing that we do is, because most common cause is uterine atony, you start the fundal massage. So fundal massage should be started immediately because massaging the fundus of the uterus can cause that contraction of the uterus, which can stop bleeding. So fundal massage, and then you start the resuscitation. Okay, it doesn't take a lot of time to do a fundal massage. So maybe even one nurse can do the fundal massage and another one can resuscitate. So it can be done in that way. So resuscitation is the same, IV line, IV fluid, bloods and everything. So once you have done these two part, then you can do other things like you can inspect the placenta to see if the placenta is complete, there is nothing left behind. Do a speculum examination of the genital tract to rule out any genital tract injury or laceration. Okay, and then also few other things can be done. We can give IV oxytocin to stop the bleeding. If only oxytocin not working, then you can add oxytocin plus argometrin. Okay, then there are options of misoprostol, then lots of other bimanual compression doesn't come in exam. In the exam, only thing that comes I have seen so far is this fundal massage. So if they give you a primary PPH patient and they ask you what is your next step of management, that's fundal massage. Okay, and you should remember what we do after that resuscitation. We check the placenta, we check the genital tract, and then if even after fundal massage patient keeps on bleeding, you give them oxytocin. If oxytocin doesn't work, add argometrin, and then later on we add different kind of medications which doesn't come in exam. So this is from Lillian Jones, and they have discussed one by one what are the things that we do. Okay, so if you have done the oxytocin or syntocin, bleeding persists, try bimanual compression of the uterus. If that doesn't work, intrauterine balloon catheterization. Then there is B-Lynch sutures, lots of options, which is not actually comes in exam because these will be done by the specialist. Okay. So you know the management of primary postpartum hemorrhage. Now coming to secondary PPH. So secondary PPH can be caused by poor epithelialization of the placental site. So placenta has been removed from the uterus. So that site is still raw and little bit of bleeding can happen. So that's most of the time the cause of secondary PPH. But it could be retained product of placenta. It could be infection of the uterus or infection of the endometrium, which is endometritis. So any of those can be a cause of secondary PPH also. So what would you do first? So first thing is you can do an ultrasound to see if there is any retained placental product. Okay, if it is not, that's really good. So first you do an ultrasound, and if patient keeps on bleeding, then IV oxytocin and argometrin can be given. Even misoprostol can be done. Excuse me. If ultrasound shows there is a retained product of placenta, then you need to go for gentle curettage to remove anything that's left inside the uterus. If there is nothing, if there is no retained product of placenta, then if you have found out that patient has sign of infection, which is endometritis, then IV antibiotics. If nothing is found, then you can just try to stop the bleeding by this method. Okay. Again, for secondary postpartum hemorrhage, first of all, you do an ultrasound to rule out retained product of conception. Then start, if the patient like having a persistent bleeding, oxytocin, argometrin, misoprostol, one by one. If you found something inside the uterus, like a retained product of placenta, then gentle blunt curettage under general anesthesia should be done. And if there is any sign of endometritis, what are the signs of endometritis? So patient will come to you with a secondary postpartum hemorrhage, so bleeding per vagina. With that, they will have sign of infection, such as fever. They can have nausea, vomiting. they can also have a abnormal parvaginal discharge. If that is the case, you take a swab from the vaginal area and even sometimes cervical area, and then start the patient with IV antibiotic, which is amoxicillin, gentamicin, and metronidazole. Okay, clear everyone? If there is a retained product of placenta, curettage will be the main treatment. But curettage sometimes takes a bit of time. So while if the patient is actively bleeding, then yes, you start the patient with oxytocin and prepare the patient to have the curettage. So secondary PPH can happen anytime after 24 hours of delivery up to 6 weeks postpartum. Okay. The next thing is blood group isoimmunization. So you know about the Rh isoimmunization. So we all know about the negative positive things. So Rh negative mother, if they have a Rh positive baby, in the first pregnancy, if that is the case, so during delivery, there is always a chance of feto-maternal blood transfusion, which means the mother's and baby's blood can get mixed up. So if that happens, many times, let's say if the baby's blood went into the mother's blood will think this Rh positive blood as an antigen, and mother blood will form an antibody against this blood. The first baby will not have any problem. But the second time, let's say again mother is Rh negative and baby is again Rh positive. The problem at the moment is that mother has got an antibody against the baby's blood. And if there is any mix of blood of these two, mother blood, if it goes into the baby's blood will be destroyed because mother's blood has got antibody against the baby's blood. So the idea is that we don't allow this antibody to form in the first place. Okay? So you give a anti-D so that this antibody does not develop in the mother's blood. Does it make sense? And definitely if this thing happens, then the baby will have hemolytic disease of the newborn. And most of the time it will be like the baby will be dead. Okay? So the hydrops fetalis and fetal death in utero is the main complication of this. So that's why every Rh negative mother should be checked for Rh antibody level first time when you see them at 28 weeks and at 34 weeks. And if there is no antibody developed, then we give the anti-D immunoglobulin at 28 weeks and at 34 weeks. So all Rh negative mothers will be given an anti-D injection at 28 weeks and at 34 weeks. Okay? And they are also given after delivery. So that is routine for every Rh negative mother, 28 weeks and 32 to 34. There are some other times when we also consider giving the NTD. If any spontaneous miscarriage after delivery of a Rh positive baby, following termination of pregnancy or ectopic pregnancy, following any sensitizing event when the fetal-maternal blood mix-up can happen, like patient went through a amniocentesis, patient had a placenta previa, abruptio placenta. So any of those, the mother will be given a NTD injection. How much NTD the mother will need, the test that we do is called Klaher test. So Klaher test will determine how much NTD the patient will require. Okay. So that's pretty much everything about Rh-ICE immunization. The other one that's also important for exam is preterm labor and premature rupture of membrane. So again, if Rh negative mother had a miscarriage, then usually you would give the NTD. Yes, it can be, Dr. Fajia. So uterine atony can be the cause of primary PPH. If antibody already formed, then there is always a risk of hemolytic disease in the baby. We also check the titer of antibody in that case, and we check that if the titer is getting higher. We will discuss that titer thing in one of our question solve class. Okay, so how we monitor the titer when already antibody has formed. Preterm labor. So all of us know that the term means 37 weeks. So if labor happens after 20 weeks and before 37 weeks, so before 37 weeks, if there is an onset of labor, that's preterm labor. Lots of causes are there. You can give it a read. And how we know the patient has got labor. So patient will present to you with a regular uterine contraction and abdominal pain. So if it is not a false labor, but a true labor pain, then definitely if it is less than 37 weeks, treat the patient as preterm labor. So we don't like preterm labor because we like the patient to be at term. So if possible, then give tocolytic medication to prolong the pregnancy up to 37 weeks. Lots of tocolytics are there. Tocolytics are medications to inhibit the uterine contraction. So you can give them atosivan, nifedipine is commonly used, magnesium sulfate is commonly used, and any of the beta sympathomimetic agent like salbutamol. So common is nifedipine or magnesium sulfate, and if it is less than 34 weeks old baby, then a steroid. And that's the treatment. Okay, so main treatment for preterm labor is tocolytic medication. What about premature rupture of membrane? So ideally, membrane will rupture after onset of labor. So pregnant mother will have that contraction first, which means labor pain will start first, and followed by labor pain, patient will have a rupture of membrane. That's normal. But if rupture of membrane happens before the labor pain, that's premature rupture of membrane. Okay? So premature rupture of membrane is rupture of membrane before labor commences. So most of the time, 50% premature rupture of membrane will go for labor within 24 hours. So what we normally would do in this patient. So you have got a patient with premature rupture of membrane. The first thing is you do an examination. So you check for vital sign, do a speculum exam, and in the speculum exam, if you see that there is pooling of liquor in the posterior fornix of the vagina, that will confirm that it is likely to be a premature rupture of membrane. So pooling of liquor in the posterior fornix. We should not do a vaginal examination in this patient because we can just induce infection or chorioamnionitis. So what would we do during a speculum exam? Take a swab for culture, start the patient with prophylactic antibiotic. And commonly the antibiotic is erythromycin. And you continue the observation. If there is no evidence of infection, continue the pregnancy until term. Or at least 36, not term, because usually we don't like it to continue up to 37. So you check the CTG, ultrasound. If the mother and baby is fine, there is no sign of infection, then you will continue the pregnancy until 36 weeks. And if patient is not in labor by 36 weeks, you just go for induction. Excuse me. So premature rupture of membrane, it comes in exam a lot. So always remember the first thing is you take a swab, start the patient with antibiotic. You do not perform any vaginal examination. If there is no sign of infection, then usually we can prolong the pregnancy until 36 weeks. Okay? Anytime there is sign of infection, you just go for cesarean section. All right. As you can see, there is a lot of abnormal pregnancy or high risk pregnancy. So we'll not be able to finish this full thing today. And I'm sure already your head is spinning. So we'll finish it in premature rupture of membrane. Now, still there is a lot to finish in our second class. So the second class, most likely we might need to take a bit of longer class, or we'll see how we can finish it. Okay, but we will finish this chapter, and then we will also finish the infection during pregnancy and also the labor. If we can finish those, it will be enough. And then we can take a bit of time to do the antenatal and postnatal care, even during the question solve class, but we'll make a plan. Okay? So try to finish until what we have done. I will give you the schedule for the November by tomorrow morning or tomorrow afternoon. So have a look at it and we'll see how it goes. And most likely your next class will be on Tuesday. So chlamydia in pregnant patient, if azithromycin is not an option, not doxy, usually amoxicillin will be the choice. So amoxy or erythro, any of those. I think there was an option of amoxicillin in one of the guideline, and the problem is that that guideline we can't actually even find out that guideline. So I'll have a look because this is a tricky situation, like what we normally would choose between both of them, because any of them can be chosen. So I'll let you know. We'll need to have a look into that. But for now, keep it amoxicillin. Okay. So Dr. Janaira, so tell me about the about that guideline that we discussed. So what was that line of doing the cervical screening? Let's open up the cervical screening from the guideline. Just give me a moment. We'll see the RACGP Red Book. Okay. Let me open the RSCGP guideline. Just give me a moment. Because this is sometimes we normally would advise the patient to go for it, but if a patient did not never had a sexual intercourse, there is no point of doing that because it is actually sexually transmitted illness. But there is a good guideline that I wanted to show you first. Okay, let's go to John Murtagh because RSCGP doesn't say anything really particular. So if we go through that, So this was the one that I was going through. So women are invited to commence cervical screening at 25 years or 2 years after the first sexual intercourse, whichever is latter. So what do you really mean by it? Either at 25 years or 2 years after the first sexual intercourse. So 2 years after the first sexual intercourse, whichever is latter, which means whichever is, yeah, so she never had intercourse. We should do it after 2 years when she had it. That is actually the case. Okay, so if she did not have any sexual intercourse, there is no point of doing it. So normally I would not actually say that, yes, you just need to do it just because it is in the guideline. So if it was whichever is earlier, then everyone at 25 should have done it, because they're saying whichever is later. It means that if she had like sexual intercourse at 25, then ideally, like normally 27, we would do it, which is unusual for Australia, that most of the patient will have sexual intercourse before 25. Okay, so for Dr. Junaira, good question. So I would actually say that no need for cervical screening at this time. But if she asks for it, so if a patient asks for it, then you can definitely do it. But no, but I would first say that she presents to a male GP asking referral to see a gynecologist for a cervical screening. She never had coitus, not a lesbian. Do you really need to do this? You can always reassure her that there is no requirement. But still, if she asks for a gynecologist appointment, you'll send her to a gynecologist. That's right, Dr. Umi. No one will get before 25. Okay, so 25 is the earliest that we would do a cervical screening. We don't do it before 25. There is only one exception which we discussed, but otherwise either 25 or later. But if someone did not have any sexual intercourse, then let's say if they they are 25, still they haven't got any history of sexual intercourse, then it says that either at 25 or 2 years after their first sexual intercourse, whichever is later. So let's say we have got 25 years and we have got a patient who had the first sexual intercourse at 25, right? So 2 years after first sexual intercourse will be in this patient 27. So if you understand what I'm talking about, so we have 25, which is like baseline for everyone. And then we have a patient who has sexual intercourse at the age of 25. So for her, the idea is 2 years after the first intercourse, which is 27. Now, between 25 and 27, which one is later? 27. Okay. That one, Dr. Midha, that's the exceptional one. The exception will not come into this. For this patient, let's see what the option we have got. Call the gynecologist for advice. You do a cervical screening, give a referral to see gynecologist. I would first reassure her. Okay, so first I would reassure her. So E will be the answer. If still after reassurance, patient wants to see a gynecologist, then I will refer. All right, everyone, we'll finish it here tonight. Thanks all. Have a good night. Bye.